Hello everyone, how are you? Am I going strong? Hello everyone, this is Dr. Jeff Blank, sorry. Oh, I'm live. Okay, thank you, Trung. Well, welcome everyone. My name again is Dr. Jeff Blank, and I want to thank you all for joining me, and I certainly want to thank my sponsors, GC America, and all the good people over at Gentrek for helping make this happen. The title of our presentation today is Direct Composite Restorations, Fast, Easy, and Predictable, and Profitable. That's going to be one of the key things we're going to talk about today. If you have no clue who I am, I certainly don't blame you. Sometimes I wonder myself, but anyway, I've been practicing dentistry for, this is now my 23rd year. Graduated in 1989. Been around the block a couple of times in terms of private practice. Been located here in Fort Mill, South Carolina, which is just a little bit south of Charlotte, about 13, 14 miles of Charlotte, North Carolina. The name of my office is the Carolina Smile Center. And here we do focus on a lot of aesthetic dentistry and comprehensive reconstruction. But we also do a lot of regular general dentistry just like everyone else. And we're certainly going to be talking about something that, of all the lectures I've done, and I've done a good bit, the name of my teaching institute is called the New Millennium Education. I know I'm a little loud. I'm sorry. I'm trying to back up. I got it. Is this better? Am I doing better now? New Millennium Education. Good. Thanks, John. And I've had the good fortune of traveling literally all over the world, teaching on a variety of topics. I do a lot of layering and composite bonding, but probably the most popular thing that I think, at least in the highest demand, always ends up being direct composites and adhesion. I think mainly because it's really the backbone of our practices, and certainly something that, regardless of where we are in terms of aesthetics, that sort of thing, we're going to be doing a good bit of. So I'm going to ask you a question, kind of right off at the get-go here, is direct posterior composite restorations, are they the lifeline of your practice, or are they just a big thorn in your side? And, you know, I pose that when I give lectures sometimes, and I like to get the response. It's certainly a little harder, obviously, in a webinar situation. But if you're like me, you probably have kind of a mixed feeling about direct composites. I'm going to throw some data out, and we're going to move through this rather quickly, but I just want to give you a general feel for where we are as an industry. And this is probably one of the best, at least that I could find, kind of reports on just how many composites are actually being done, particularly in the United States. Interestingly enough, this study was done and released in 2007. I try to keep current on these types of studies. And when the study was actually trying to prove to the, basically the industry and the government not to ban amalgam, which is kind of an interesting thing. So as you can see, the credits are down at the bottom. But moving on, the reason why I like this study, it was 166 million restorations placed. Basically, I think it was in a 2-year period prior to 2007. And you see the breakdown there. 73 million were actually posterior composites. And by the way, these are just studies of restorations on back teeth. 52.5 million were amalgams, and 36.2 million were crowns. And if you think of it, and I would like to think, just by the nature of the study, crowns can be inlays, onlays, some sort of direct type restorative. And these are the types of things, obviously, we do on posterior teeth. But you see the breakdown, we actually have seen direct composites breach, and it's been that way for several years now, higher than that of amalgam usage. And, one of the things that's interesting, and as you read through this particular study, if you have the chance, you'll see that 64% of those composites that were done were actually in replacements of other restorations, the majority of which were actually amalgams. And the reason I put that up there, I bet a lot of you are thinking, well, that's kind of basically what I'm doing in my office. Kind of aside to that, and maybe somewhat antagonistic to it, this is one of the best clinical longevity studies that I could ever get my hands across. 1,700 posterior restorations in which the live patient divided the restorations up equally among amalgams and composites. And they did a study to determine longevity. You see the table there on the right. And really what we're pointing out here is the failure rate of direct composites. And kind of casually speaking, pretty much here's how it broke out. Over a 7-year period, the big ones, that's 3+ surfaces, 40 to 50% of them failed. And failure was defined by a number of different categories, some of which had to be actually completely replaced. Others had recurrent secondary caries was the primary reason. But the small ones, these would be the 1 to 2 surface ones, pretty much 94% of those are successful. So that ought to start telling you something. Big posterior composites, one, and the way I kind of look at it is basically I don't care how, we can do them and do them well and beat these odds, but there's going to be a lot of work and trouble and everything else. So despite the myriad of direct restorative challenges we face every day, not all the things that we come across are suited for direct composites. And I think that's one of the problems that we seem to have in enjoying doing composites in our offices. Unfortunately, we try to use it as white amalgam sometimes. And, what I'm trying to point out, and obviously the point of this particular webinar, is to hopefully give you some insights on ways that I've found that we can actually be able to do direct composites and have them be what the title said: fast, easy, predictable, and profitable. And, case selection is really going to be everything. And a lot of that is mindset and the way we present dentistry. And when you take it and get serious about it, look at other studies, and you see it down here at the bottom, but as dentists, and I've seen different, this one was just pretty high, 78% of our time is basically doing fillings. Now, that could be amalgams or glass ionomers or composites. But if you look at our industry as a whole, when I sometimes wonder, why does everybody want to keep hearing things about direct composites? Well, I think this is really the answer. It is what we do the most. But it also can be, like my first slide that I put up there, it can be the absolute backbone of our practice, or it can be the biggest pain in the rump that we can actually deal with as clinicians. So one of the questions I ask you is it wise to spend 78% of our time on procedures that could have a 50% failure rate? And, I want to be clear here. This isn't going to be a direct resin restoration lecture, but I want to be clear, case selection is going to be everything. And if we start spending a lot of our time trying to do posterior composites on teeth and do them well and defy the odds of them failing in a 7-year period, because I know many of us have huge ones out there that have been out, 15 years or whatever. But bottom line is, it's what they say in basketball, that's a low percentage shot. And if we're spending our time and we're frustrated in the chair, I think we might not necessarily need to look at the way we're doing it. It's just why we're doing it in our treatment planning case. Because as we begin to look, if you really want to see where the focus in our industry has been, is that we're really seeing, I'm really having to push it away, sorry. Is that better? I know I'm loud, I'm sorry. Okay. This endless search for white amalgam. So, if you look around, by the way, I'm not disparaging all of these, and as a matter of fact, I've actually been on beta groups and everything else with a lot of these products you see on the screen. And the bottom line is we need to do that. But if you really realize why these products are being developed, it's not really for early intervention or initial caries types restorations. These are largely going to be either you live in an area where you have just massive caries, where you're coming in and people have bombed out teeth, or for an entire segment of our industry that is looking to replace amalgam with composite. That's what these things are for. And they need to be there, no doubt. But, if we sit back and look at proper case selection, the bottom line here is that everything is set. The stage is set. If we want to be fast and predictable, all those things, we really have to be mindful that case selection is everything. We want to capitalize and be quick to early diagnose. We want to find these lesions while they're small. We want to choose those that are going to be winners, that are going to be in healthy enamel. We'll talk a little bit about that in a minute. Proper isolation. You really want to minimize the number of interproximal contacts, and how you prep these teeth are going to be very important, certainly how you restore them. And then you obviously want to put them in patients that know the working end of a toothbrush. When you look at secondary caries being the failure mode for pretty much most direct restorations, obviously both amalgam and composite are going to act, in a negative environment. Composite's always going to, produce poor results in terms of longevity. Now, what happens when we really try to overdo it, And I'll say here, if you look, I think you can actually, let me show you my cursor. I can point. If you look at this particular case over here, now, this is a case that I'm actively doing. And what you'll see is, if this has been the treatment plan, this quadrant over here looked like this quadrant over here. Now, this patient will say, gosh, I had amalgam I had fillings in these teeth, doc. Can't you just fill it? If you look at my first bullet there, I have a saying. It says, fillings fill holes, crowns, inlays, and onlays restore badly broken down teeth. And the reality of it is what we do and what was done originally here, and it's usually for good reason. Very often these fillings are placed in our patients as we see them as adults when they're teens. And, a lot of people aren't doing, full crowns on a 14-year-old. So amalgam is a good choice for a lot of those particular cases. However, into adulthood, we begin seeing the so-called crown of the ear club, all the demise that comes from cracks and secondary caries and that sort of thing. But the reality of it is, if we try to segment an ideally treatment plan, dentistry for our patients, when something needs a crown, falls in the category of needing a crown, treatment planning it for that. For instance, I would ask you, what is your treatment plan for this case that you see the cursor on here? Obviously, some of us may be doing 3 fillings, some may be doing 2 fillings and a crown. These are all things that really make the difference in us becoming incredibly frustrating. Because if we do crown this tooth, these are 2 very easy to do, even though they're rather large, very easy to do direct composites. So just because it had a filling in it before doesn't mean it gets a filling again. It's not always the right thing to do. And we do know that when we have large multiple surface cavity forms and poor isolation, high incidence of caries, a lot of interproximal contacts, particularly if they're wide. And the big no-no is when we actually start finding some of these amalgams having secondary caries that get down on the cementum. And the list there of studies showing that basically direct composites on cementum leak like sieves. If you're down there where you see both of these and you're planning on placing a composite, I can pretty much tell you you're not going to make it the full 7 years. Nothing really seems to seal down there in terms of direct resin. Glass ionomer, on the other hand, does very well. Sandwich techniques, amalgam does very well down there. Indirect restorations do well. But these are not candidates, and you're betting on a loser. This is not going to be fast. This is not going to be predictable. And I can tell you it's not going to be profitable in the long run either. So if this is our goal, we have to realize that fast, easy, predictable, and profitable are all predicated on early caries detection and minimal surgical intervention. So I'm not trying to push this, I'm not trying to get on the soapbox, so to speak, but, in my practice what I found is it's just too hard to try to use white amalgam on a day-to-day basis and be profitable and to actually do a good service. I find myself cutting corners, ending up with open contacts, those kind of things. So I've begun to focus on what are ways that I can catch these things before they become a disaster. Because, caries has been a paradigm, pathological disease, and we've always known that. It is a bacterial process, but it happens to be the only bacterial disease, particularly in the United States, that we wait until the surgical intervention is the only cure. We have ways now that we can catch it earlier than traditionally we could even in, say, 5 years back. And we also can manage some of this caries with remineralization things, and I wish I could spend some time on ways to do that. But we always need to be focusing on ways that we can catch things before they become huge so we can do so-called winners when we do composites and be able to charge a good fee for them and do them fast and have them be effective. But problems with early detection is that if all we have is an explorer anymore, we realize that, we've known this for years, that, there are plenty of studies out there that show that an explorer is only 42% accurate in determining occlusal caries. If a blunderbuss and vaginations, you can't see them on x-ray. You basically have fluoride that actually mineralizes this area where it's nice and firm, but yet you've got decay building up underneath. So you have all these issues going on that make it really hard to kind of figure out exactly what's going on. So we have other devices that are out there, and there's several of them. I'm certainly not saying any one is better than the other. I've basically used all of them. I think everybody full knows that Diagon has been out for a long time, and I'm going to show 3 here, and they all are based on laser fluorescence, and what they're doing is using a specific wavelength to actually measure the actual illumination or fluorescence of porphyrins that are actually emitted by caries-causing bacteria. And this one has a numerical scale, and they now have a cordless model. If you want basically kind of the watered, not necessarily watered down, but just the down and dirty version, Midwest Caries IDs, it beeps when there's a cavity that goes all the way through enamel. It's affordable, easy to use. You can pass it around from room to room. It's obviously sterilizable. But pretty much the brainchild today is pretty much the Spectra, and I guess you've seen all of it, and I've managed to get my mug kind of attached to it just because I've been using it since it pretty much came out of Germany and started being actually launched here by Air Techniques. But what you see is this so-called Doppler radar concept. And, I've written many articles talking about using laser fluorescence as a surgical guide. For instance, and I don't even do it, you see obviously asking my assistant using it here. And, scanning teeth, and as you can see, let's use this example on the lower right here, what is that? Is that going to be a sealant? Is that going to be, one of these preventive resins that you're just going to have to kind of, remove some enamel and, just debris out of the actual groove and place a sealant type material? Or is that going to be something bigger? And unfortunately in this one it turned out to be a whopper. And if you see yellow like that, you're actually talking about getting close to the nerve. And I bet you've been in a situation, you thought you were going to be in there, maybe not even numb the patient up, and this is what you end up happening, and I bet many of you are shaking your head because you can kind of go through the progression. It's like, oh my gosh, you drop into this business and it's deeper, and I call it going from missiles to guns to, now you're using knives. You're basically hand scraping at this point, placing a base. And of course, all the while, your patient just thought they were going to have a little in and out zit type filling, and, it really turned out to be one of those things that was just a major, major nightmare and a big schedule wrecker. It's hard to make money on this kind of thing if you don't know what's going on. But, keep in mind, another way to kind of kill your schedule and kill your profit is if we continue to use GB black type preparations for composites. Not only is it contraindicated and would be considered egregious by many, it actually makes more work for you. Now, G.B. Black was a brilliant man. He created preparations that were designed for a material, and that material was amalgam. Well, if you're using amalgam, then you're going to have to do all those things like, for instance, extend a 0.5 millimeter into dentin. You're going to have to probably get into the self-cleansing area. This extension for prevention concept, I'm not real sure about that one. That's one of those things that, honestly, what you're doing is rather than allow that, even though the area of the tooth is not diseased, let's go ahead and amputate it before, in fact, it does become diseased. Those are all things that, end up being, reasons not to actually, cut those kind of preps. Today, what we're doing is with pit and fissure lesions, we're really going in and opening up the area, and we usually try, show you here on the right, what you want to do is open up the top part and look to see if you have this blunderbuss thing going on. Very often, as you see here, you don't. And then you would use round burrs in this area, and really the width of this hole here is 100% dictated by visualization. Now, when we talk about interproximal lesions, cutting the traditional GD black class 2, not only is that egregious and cutting away a lot of healthy tissue, it's not necessary for an adhesive restoration. It also means that you have more filling to do. And if you destroy the entire interproximal contact, then you have to build it back. And you may be saying, well, maybe, building contacts is my big problem. I'm trying to figure out a way to manage those. Well, kind of where I'm going with this is if you don't have to remove the contact, then for heaven's sakes, don't do it. It's in nobody's best interest. And, you're obviously going to have to change your armamentarium a little bit. Now, you could probably use your traditional burrs. Excuse me, but if all you have is a 557 sitting in your burr block, more than likely you're going to be pretty aggressive. And, there are several out there. SS White obviously came out with their fissurotomy set and fell under a good degree of fire, and I believe rightfully so, for being the so-called diagnostic. They were advocating this so-called, surgical exploration. You were basically going in and doing a surgical biopsy on all the grooves to see if decay was in them. I think that's probably a bit egregious. But the actual burrs, if you're a carbide person, these are very good carbides. Their length is actually proper for not going through enamel. In other words, if you stop at the head of these. But Comet, I'm a big fan of diamonds. I'm a big fan of Comet. They have the same sort of situation, same sort of measurements, and a great degree of nice little, what I would consider diamond round burrs that are perfect for this. Because you can see, when you look at these, you're going to get a little deeper here. It's just some fissures opening things up. You found a little spot over here. It's nice to have, what you need in your toolbox to be able to do this. But these are the types of so-called quadrant dentistry that you should see here in minimally invasive. This is the money maker, guys. This is fast, profitable, and easy to do. Now, obviously, this is a big target. Hopefully, you're doing it. Obviously, a MO and a DO, an MO and a DO are actually treatment planned for this particular tooth. And, obviously, the bigger one was done first. And, again, I'm getting this from DHE. As you can see, these are not my work, but it's just good examples. And as you can see, the size of this cavity form allowed visualization of the MO, and then basically that's done as what you and I probably would consider a class 5. Now I'm showing you these particular cases because Obviously, trying to put a stiff, traditional hybrid, nano-hybrid type material in there, particularly if you don't have good isolation and that sort of thing, it's very hard. 9 times out of 10, you try to wipe that material in here and it just comes back out. It's pretty clear that a good flowable material would be better, and traditional flowable may work there. However, as you start getting on marginal ridges, and we know on a class 1 occlusion, we're going to have occlusion right on this actual marginal ridge. We're going to need a material in here that actually has the rigid capabilities of being able to withstand that kind of load plus maintain contact. But as we speak about contacts, here's the deal. You do not need to break it. Now, we've been taught not to do this. When in fact, I get this, when I do hands-on, everybody wants to know how to maintain contacts. Well, the reality of it is, if decay doesn't get rid of it, we don't need to get rid of it. Look at it here. As you can see, now this becomes a little tougher when you don't break gingival. Typically, you're going to have to run some sort of diamond lightning strip through here to get a matrix band through. But the idea is all you have to do is get enough clearance through here to get one of those really narrow kind of, what I call HO bands, HO bands, those 0.0015 ultra thins. Garrison Dental Solutions sells those. And just slide it through there and wedge it, and you're done. The contact has been maintained, and you really don't have a whole lot of stress associated with it. And again, here, is hybrid materials ideal for this? Traditional materials? Probably not designed to do that. Now, the tunnel prep is not one that I'm a big fan of, at least this access here. I've been using this for a while, and I don't remember where I got it from, so if these are your pictures, tell me, and I'll be glad to give you credit. But this type of tunnel, and maybe you have an understanding about why that can be difficult, is there are big pulp ones in here. And if you hadn't nicked one of those yet, if you get particularly on a young kid or something like that, the likelihood is going to be there. I'm sure we're all aware of that. The other thing, and this is why I keep this in my lectures, is visualization in here is very tough to whether you've gotten all the decay out. I'm a much bigger fan of having a facial and lingual access, okay? But obviously it can be worked. What's the purpose of this? Is if you can leave this intact, and that assumes that you didn't have to really undermine a whole lot of it, then obviously, you're going to have a more solid restoration. But the facial approach, sometimes it seems a little more aggressive, or a lingual approach, much easier, and you tend to leave this all intact. And if you follow any Graham Milicic stuff about stress distribution, if you don't violate this occlusal zone, then basically you end up with a stronger tooth overall. But again, these are the types of things that we see. This is, again, good quadrant dentistry that we want to try to shoot for. And this is really, like I said, the moneymaker. But how do we restore all these things? We've cut all these little slots. You've got this early intervention stuff. Well, GC has come out with a new product, and it caught my attention for a number of reasons. But Genio Universal is a flowable resin that actually has some unique qualities that make it probably, and if you're familiar with GC, you probably know that they're probably in the forefront of all the manufacturers globally in the minimally invasive concept. And with minimal intervention, obviously you want to have restorative materials designed to go with minimal intervention type preps. But what we've run into in the past is whereas we've had plenty of flowables, some of which are reasonably durable, something along the way in terms of either working properties, rheology, handling, finishing, polishing, those things weren't there. So when they developed this product, their primary use was actually to create what they would call a liquid hybrid material. This is just like any other hybrid, nano restorative material that you can think of out there, but it happens to be in flowable form. Now, it seems a little, somewhat, odd that you could even be able to do that. But when you start looking at the indications from this, maybe your mind starts to wander a little bit. Now, I think we've all used flowable materials, and we certainly, maybe we've used the liquid core buildup material and realized, gosh, I wish I could do a filling out of this stuff. Well, now you can. And that really is the whole concept. I hate to use the word duct tape of dentistry kind of deal, but, it's far better than duct tape. That implies, obviously, something kind of shabby out in the garage. But this is just the tool in the toolbox to handle so many different things, everything from splinting. We talked about minimally invasive stuff, but we're talking class 1s, moderate class 2s, about as big as you really want to go. You will never use anything else for a class 3, never. Because I know you struggled just as I to take that little compule and stick it in that hole in the back of number 9 and squirt it in there and find it just comes back out stuck to the actual gun, and so you wipe it in there and then you're trying to kick it in there with some instrument. Imagine just matrixing, putting a matrix around this and filling it up like you're filling up a gas tank. Now, Class 4, yes. I think this is a little, ambitious, for this size. I've never done one quite that big. However, when a patient comes in and has the little crack or the small chip, those type things, the ones where you really struggle to actually be able to get something adapted, you end up with white lines. Listen, I've done it. Perfect for that sort of thing. And, of course, Class 5 restorations, too. So what are the main features? Obviously, flowability. This is a flowable. And you can see that, the handle design is such that you have to actually get your palm on it. It's designed to hold it, obviously up here around the handle. It's got a broad thing to fit in the palm of your hand and a good, ferrule to be able to grab and push. But it comes with these disposable tips that are long and thin that get in areas that regular, flowables don't go. But here's the concept. Polish, self-polishing, flexural strength. Well, let's look at some of those things. I'll show you those numbers in just a minute. That's what makes this a superior material, at least in my mind, compared to pretty much anything in the flowable class that's out there now. So it extrudes like a flowable, but handles like a hybrid. Pretty good test. This is, I understand flowables, and I'm not knocking them. Flowables are designed for two things, and they really should have two categories. Some people use flowables as liners, and they want them to be runny. They want it to flow over the base of a prep, that sort of thing. Other people use flowables. They want it to stack. They use it in a Class 5 situation. Well, really you end up having to inventory, too, when you want to be in that kind of situation. But if you look over here at Genial Universal Flow, when they place it on a vertical board, instead of running, it sits there just like this. However, and I'll show you pictorially in a minute, if you were to take an Explorer and begin actually trying to push this, you could begin with kinetic movement to move this in any shape you want. You literally could make a J for my name out of this stuff, and it would move rather easily just by the kinetic pressure associated with an instrument. So we'll see that in a minute. So really and I know I'm getting lots of questions. I'm going to try to answer them all at the end, so keep typing them. And I know I'm talking too loud and I'm talking fast. Sorry. I got you. Sorry. The flexural strength. Now, that's going to be a key thing, and it's always been the litmus test for what is a good posterior material. The big qualifications by the ADA and whether something actually qualifies as a posterior restorative material in terms of flexural strength. Now, when you start comparing this, on the top here in the pink is obviously flowable materials, and these, if you'll look, you've got, Supreme, you've got Prisma, Aesthetics, Premise, pretty much all the major players that are in the so-called posterior or universal composite market. And if you look at flexural strength with, out here somewhere around, 170 or so, compared to the flexural strength of flowables, it is far exceeds flowables by all strengths. But it even exceeds, if you look at some of these, really good, and I'm a big fan of Supreme Ultra and Aesthetics HD, this material is definitely on the same train in terms of durability and when it comes to just overall strength. Wear resistance is really the big player, and another ADA criteria to use this as a posterior restorative material is you've got to basically go through a 3-body wear line filter test, as you see kind of here. And what happens if you've used a flowable, say in an occlusal, could be a small one, but it was actually a filling, but you used a flowable material. I bet you've seen 4, 5, 6 years down the road, it ends up being all ditched out. The food bolus itself will wear away most of your flowables out of the occlusal surface. And if you used any of these, then probably some of the candidates will wear away. And in this case, you want a low number. And here is Genial Universal Flow way down here compared to Flow It and Supreme Flow. High wear rates. But again, what they're made for instance, this is an excellent liner. Again, not disparaging these, but this just has something better even than traditional composites in terms of wear. So what is it? Well, the uniqueness about it is, and they may not like it, a good comparison, I think everybody knows that, with 3M Supreme, that it was originally the first nano composite, and I think a lot of people at least have the concept of what nanofillers are. The first original nano, obviously, was, a microfill. It's 0.004 fumed silica. That would be a nanoparticle, so they, in fact, could be qualified as nanos. But if you remember, that's why they polish so well. Again, that's one of the major features here. But with something like Supreme, rather than filling it with silica, they are actually manufactured, engineered nanoparticles. Now, Supreme actually aggregates those in clusters, and they've got some proprietary, formulations that actually keep those clusters attached to the resin matrix and other individual nanoparticles. But it is postulated that it is possible that some of those clusters could fall out, which is reminiscent of particle plucking. You see that in hybrids, traditional hybrids, ones that, don't stay polished very well. When you have a true nanomaterial like this, then, one that is, and again, flowable form, but it's 69% filled by weight, which is right, up there with the big guys. 70, you see some into the 80s by weight in terms of filler content. It has to be somewhat lower or it wouldn't flow, but it's as high as it can go. You're dealing with a material that's incredibly strong and obviously very durable with high polish. To add one more selling feature is 15 shades. Now, they're not trying to be the big box of crayon and the so-called master's kit, but I think we all find, different things that we need to use in our practice. Some things that I like, it's 15 shades and 3 opacities. Probably the big selling features in terms of shade for me, and I know you can't read this. I need to get a better slide, but the reality of it is that they have all the basic, so-called A, B, shades. They have some opaques, B1, B2. But the things that I like is the cervical shade. And if you've ever used Gradia, that was something I loved about Gradia. Cervical shade is kind of a universal shade for pretty much class 5s. And that would be root exposure. Pretty much all roots are this shade. I don't know what shade that is, but I bet you've tried to put the darkest thing you've had in your box in there. I know sometimes I feel like I want to rub some dirt, from my shoe on it to make it match, it's so dark. But their cervical material, and I'll show you in a minute, matches just about everything. And one of the other things, and I don't know if you can read it, I'm having trouble reading it myself, is that they actually have an A enamel. And I'm going to show you that because I'm a big fan of replacing dentin with a dentin opacity and replacing enamel with an enamel opacity. And if you layer it the way I show you, you're going to do minimal polishing and you're not going to find the edges. They're going to be beautiful. And with their polishing capabilities, then I don't really want to have to polish, to be honest with you. And that, I'm going to show you, I don't polish a lot of them. So all this is we're geared for speed. It's the key thing. So let's go ahead and do some. I know you want to see some teeth, but I had to kind of set you up there. So let's just do a basic class 1. Now, in my full day lecture, I showed that, we actually ran a Spectra on this. And I got to tell you, it's kind of hard not working with Spectra anymore because I think you'd have to agree, you really wouldn't know what's going on under these sealants. It'd be pretty easy not to do anything. And to be honest, without Spectra, and it's one of the few caries detection devices that actually can use around existing restorations, you'd be hard-pressed to know that you're actually going to run into this kind of trouble. Usually what we've done in the past is to see if we hang up in a certain area, and my philosophy would have been if we hung up here, I would have gotten them both out. But, as you see, the worst area was here and here, which is here and here, and that's completely hidden on X-ray and everything else. So we go ahead and get all this stuff out, and as you can see, it doesn't turn out to be a total so-called sealant bomb, but it's a heck of a lot more than replacing that sealant. And we've got to obviously bond to this stuff. Now, for speed here, I'm talking too fast, and I don't want to include too much here, but the bottom line is I'd love to talk to you about adhesives, because you've got a lot of choices. And I think everybody knows that you have total etch and self-etch, and those are divided up in multi-bottle and single bottle, and you have the so-called 3-step and 2-step, and then the so-called 7th generation all-in-one bottle thing. Now, we all want this. Now, again, I have an entire half a day on, the advantages and where these belong in the practice, but I'm going to give you a kind of cut through the chase here. With these adhesives, you've got 3 distinct mechanisms of action, of adhesion. You've got total etch, which obviously dentin and enamel are etched simultaneously and then rinsed. Self-etch, in which no phosphoric acid actually touches the tooth at all. And then selective etch, in which phosphoric acid is selectively applied to only the enamel area in order to increase adhesion. And I'll tell you where I am today. In posterior direct restorations, and I believe I'm well supported in the literature in saying this, there is absolutely nothing in the literature that can convince me that total etching, a posterior direct composite restoration, is a requisite or even advantageous given the science that we have available to us now. So again, total etching posterior teeth, there simply is not any reason to be doing that. Obviously, if you don't own any self-etching materials, you're going to have to, but selective etch is what I'm doing almost universally now with my posterior restorations, and I'll give you pretty much the reason why. This selective etch technique One, it's long been known that if, the weak link to self-etching materials is, if you look on the left, they don't generate a good etch pattern, particularly on uncut enamel. However, if we will apply phosphoric acid for a little bit and then put a self-etcher on it, we actually get great etch patterns, of course, because we use phosphoric acid. Now, adhesion goes up, actual marginal leakage, marginal staining, everything else is significantly improved. And so the concept has always been, well, etch just the enamel margins, don't etch the dentin. Use a self-etching material because since they've been invented, they've done really well and considered superior by many researchers on dentin, but just the weak link has been enamel. This seemed to answer it. However, if you're sloppy, there were some problems. You have potential issue of that stuff, phosphoric acid, getting down on the actual dentin, and obviously what happens when it does get down on dentin, it's going to demineralize and remove calcium and phosphates, and the potential was that it could etch farther than these self-etching materials could actually penetrate. So say you etched all the way down to here, but the adhesive that you were using could only go to here because it wasn't designed to be used in a self-etch mode, then you could have a void that would fill with water, and then you would end up with nano leakage, water trees, semi-permeable membranes, bond degradation, secondary caries, bond failure, obviously all kinds of problems. So it became this just giant race not to get anything on the dentin. But you and I know, even when we're rinsing it off, some of it gets on there. And our busy life, it just happens. And so a lot of people, and obviously GC being one of them, began looking at what kind of things would actually make it possible to slip up. In other words, get some etch on dentin. And they came out with Genial Bond. It is pretty much the kissing cousin to G-Bond, which is its predecessor. And they improved bond strengths, but they specifically designed with a lot of proprietary formulation and the elimination of HEMA and several other things to make this a self-etching material that works very well with a total etch, a selective etch process. So this material, like many others, I could name several others that are out there that work really well with both modes. But again, I wouldn't total etch with that product. That's not being advocated. I'm curious to see how it would perform, but they haven't actually given me any data on that as of yet. So here's how you do it, of course. There's our 2 lesions, selective etch for 15 seconds, rinse. And by the way, when you rinse, every self-etching material, including obviously Genial Bond, is designed to work best on a dry surface. So after rinsing, you're going to just desiccate this like it was just enamel, the inside dentin and the outside. And you're going to apply this to that more or less desiccated surface. And what I like about it, if you know anything about self-etching systems, they all have a dwell time. They have to do something. There's a chemical thing happening. And some are as long as 40 seconds. This is 10 seconds, and to my knowledge, you can prove me if I'm wrong, show me, it is the shortest dwell time of every self-etching material out there. If I'm trying to do things fast, then obviously that's going to be an attractive thing for me to not have to sit there for 30 and 20 and 40 seconds, that sort of thing. Now here, as you see, when you begin using the A1, this is the dentin body material. Now, it's more than just filling it up. Now, you do have a C-factor situation. You don't want to connect the sides. And there's 2 reasons not to connect the sides. One, if you connect the opposing sides, you could have some contraction stress, even in these small restorations. But more importantly, if you actually, because you can, stack this material along each slope, as you can see was done here, then the amount of finishing and polishing that you have to do becomes next to nothing. Now, typically I'll lay it in, and when I pull this out, I'll take my Explorer, and I'll show you manipulating. It's our last case here today. And I will manipulate it to where I want it to be. And then sometimes I'll just go ahead and fill it up in here and divide it with the Explorer. It just depends on if it's a bigger restoration, an IPC instrument. But I'll get it laid out, and then, of course, I'll just light cure it. Now, and I noticed when I was looking at this, I left out, but this is, I meant to put the picture of the actual A enamel, the clear shade. And as you can see, this is a really clear material. This is applied, and the same thing is done. You want to follow these slopes. And again, there's a lot more anatomy in this, too. This one was kind of just ground out, so to speak. But again, you will lay this in here, of course, once you get it where you want it, with anatomical proportions. And that's another good thing, is finishing and polishing on these small restorations. Because you have the slopes of the adjacent teeth, you don't have to do much actual finishing and polishing. So there's your before and after. Again, teeth are a little desiccated, I know, but, it's just one of those no-brainers where you can't find the seams, and it's done incredibly quickly. And that's one of the key things I like. The durability on these second molars is something you need. Here's the case we showed you before, and I thought this just for other mixes. Understand, quick to cut the preps because they're small, but I'm still filing this or billing it out as an occlusal, an MO, and a DO. Okay? Now, it was done, obviously, no need to cut all this business out here. If you cut all that out, one, it's just, I guess it's just tearing up a tooth in my opinion, but there's no decay there, and that's just more for you to fill. Now, if you tried to fill these areas with, traditional hybrid material, I think you know as well as I do, that can be harder. If you try to push a little bit of hybrid down in there, I guarantee you'll have a white line. You probably have polymerization, contraction, stress issues, major things. So really what we see is selective etch, and notice I'm not doing this one on purpose, genial bond, then I'm stacking this in, just like I said, and as you can see, we've kind of layered that in there and light cured it. But when I go to fill the box, we just take an Explorer, and then you'd have to use the flowable here, okay? And this material lays in there nicely, doesn't spill all into the other prep, everything else. And then, obviously, that's light cured. Sometimes I have to take a burr, but most of the time I can just take one of these little Comet sanding strips and pass it through there and maintain that contour as you go all the way through. And then, as you can see, kind of maintain that contour. Now, really all that's left is to do this DO. Now, again, it's back. Now, you understand, anytime you're doing anything where you have to build a complete contact, you're going to have to use one of these bi-kind rings from Paladin. The Garrisons were one I've been using. This is the 3D composite type. I think it's just the most superior. I'll show you some of the different kinds they have. But, several of them out of the V-ring, whatever you're using. But trying to use a traditional toppermire, you're really kind of kicking yourself in the head because you have to separate the teeth the width of this band, or you're going to have a space the width of that band. And by the way, they make these things very thin now, Garrison does, because this liquid by no means is going to be able to push out against this. So it's the pressure of the bi-kind ring that's creating the contact. That's a guaranteed contact every time. So much so that you have to keep hemostats on hand to pull these matrix bands out. So that's how those are done. Now, again, another Spectre case, and if we go through and we look at these things, it looks just like old clear sealant material, but we see like we're getting ready to have a little boo-boo in there. But just showing, and I've showed the case, and I just kind of wanted to fill it all the way through. Another selective etch. And again, this one is one where I went in and didn't use the A enamel. I just used A1. Laid it all in, and that is it. That is before polishing anything. And very often I'll go in and adjust the bite. Often I might have some flash or something. I'll take like an enhanced cup and knock that off, but I don't even have to adjust the bite. And that's a money saver, big money saver. Typical class 2. Again, here's the Garrison, the composite type 3D is what the system is. And the way they advocate doing it is place an actual your matrix band in, and then it would be this. You place this sectional matrix, use your wedge and hold it in place, and then you set this right on top of the wedge. It has a little V to actually go over that wedge. And even though lizard wedges and everything else we use will work fine, one of the big issues, one things that I like is they also have these very long wooden wedges, which I've become addicted to. Garrison sells them, because if you think the wedge has to be pretty long, it has to go from here to here, or otherwise you're digging to get it out very often, or to push it in for that matter. And they have little Teflon coated ones, because here's what we're finding. They've all been stainless steel in the past, but a lot of these new bonding agents are actually capable of bonding to stainless steel, and we're having difficulty getting the son of a guns out. So again, those Teflon coated ones are pretty neat. But there it is, genial bond, and it's kind of a no-brainer at this point, but just more of a case demonstration. And again, it's a filler-up kind of deal. In these, it's pretty difficult to really try to lay in a lot of anatomy. It's a real small thing. And, one of the nice things is these tips are very small. Do you see how that fits all the way down in the box, just as a traditional, flowable tip? But what's better is because it's long, your visualization in here is so much better. And that's a big selling feature. Now, on a case like this, I'm going to have to obviously create the anatomy. So I would come in and obviously use fine diamonds. I use the actual composite adjustment diamond kits from Comet. You can use ET. I'm a big fan of diamonds. I think people that use a lot of carbides, you end up creating a lot of it seems to be more nicks and abrasions and kind of facets on the tooth when I use carbides, but I like diamonds and have a good feel for them. But this is pretty much my standard polish. An enhance point, and that'll knock off any flash I might have left. You can adjust the bite with that. That is a finisher. And then I'll use one of these Jiffy brushes. There are a number of them out there, but that'll be about it. Because really trying to use 2 and 3 grit systems on a restoration like this, my joke is you only want it to be as shiny as it will not collect stain. Because nobody's ever going to see it but you. Now, if you want to, sit there and burn up a tooth, creating all that heat, help yourself. But basically, it's these 2 things, and I call it a day. Again, that's a Jiffy brush, and then Comet makes those brushes. They're impregnated with polishing materials. And as you can see, dehydrated, it's immediate. Little glassy looking, definitely can see it in there, but a good polish, and that's what we're looking for. Now, this is kind of a great case, and even if you're not a big fan of using this stuff for its intended purpose, GC I think sometimes finds humor in me because I kind of like to take it out in the garage and find other things I can do with their products. They have a dedicated core material, and I'm certainly not trying to cannibalize another product from them, but I will tell you that I do a lot of full mouth reconstruction, that sort of thing, and I have used and worked and been on the development of many of these core materials, dual cure materials, actual materials with bulk cure up to 6 millimeters that were hybrids and that sort of thing. I've never, I'm at the point that if you took Genial from me for everything else, I probably might be able to find something that wouldn't like it. But if you took it away from me using it as a core material, I don't know that I know what to do. The bottom line is that, in this particular case, and let me back up, is obviously this guy's got a lot going on. And as you can see, we have plaque, caries control, everything from a bacterial standpoint has been controlled. He still has some gingival inflammation, but he's got infestation in the actual lesions that he has there. And, we believe, he won't admit, we believe there may be, some drug, alcohol component to this. But at the best, he was under recare and temporized for a while and came in ready to basically move on restoring these teeth. You can guess, and we suspect maybe meth or something to that effect, because it's only on the facial aspects, largely on the front teeth. But, he's all but signed an affidavit saying that he doesn't do that anymore. But we've got to go in and restore these teeth. And, this is typically what I do. And I really, in a minimally invasive approach, it would be easy to think that we need to do full crowns on all those teeth. When in fact, like I said, most of the decay was limited to the facial aspects and in the proximal zones. But what I'll do is I'll prep these things, and we treatment plan these all for veneers. They're heavy use of the word veneer, but they're veneers. In other words, they aren't 360 degrees, with the exception of one tooth, which, if you go back and look at that before, shows really working hard to conserve tooth structure, which is part of my philosophy. I will do the preparation, and I will do my dangest to stay in enamel wherever I can. And then when I find decay, then that decay will basically be handled with Genial. And it'll be handled in potholes and pock marks and that sort of thing. But there's Genial bond being applied. And what's nice is, in this particular case, you see what I'm doing is I want to build this up. And, I'm from the East Coast, and hopefully everybody's at least been to the beach and taken that, we call it drip castles, where you can pick up sand and that wet sand and actually get it to stack. That's the best way without you actually touching it. I'm sure your rep would love to let you play with it. But I'm literally showing you that I'm stacking this material. You do kind of need to rest it against the wall. It has some, obviously, kind of van der Waal type hydrogen attraction to the wall. But you can slowly stack this up. And you don't want to, you don't want to violate 10 millimeters at a time. I mean, obviously, all these composites shrink, so you do want to try to keep your increments, in a normal range as you would a hybrid. But nothing would fit better in here for these things. And as you can see, here we go with, again, 3/4 crownage kind of concept. This is going to be our only full coverage when we get through with it here. But this one, we actually did a root canal and had to place a post. It was a wipeout. But if you look, we really busted our humps not to make these overly aggressive. Now, if my veneer is going to cover the decay, then I'm perfectly fine. But I like to have my margins in sound tooth structure with these expensive restorations for durability. But flowable, this has got flowable written all over it. And if you're going to look at the actual, go back to ADA requirements for a core material, this meets all the requirements for it. And then here, when it's all said and done, it looks like a pretty heavy-handed veneer case. I mean, if you look at my preps here, I'm pretty proud to say that we're really still in enamel, and the majority of these, you can see a lot of enamel out here on the canines. A lot of the heavy margins were largely dictated by a lot of the Class 5K. But again, Genial helps me do that, you know, and allows me to be so much more conservative. It'd be pretty easy to just whittle them down. I will tell you that. But obviously, you know, that's not in the best interest of the patient. Just as an aside, we do what we call shrink wrap chumps, but as you can see here, we paint with this Equia coat. Probably no air inhibited layer. It's got to be the best glaze for temporaries I've ever seen in my life. Probably another garage use for Equia, and there's our final, you know, before and afters. You know, I obviously had a lot of work to do with this guy. And as you can see, you know, we just basically did 8 units. That was largely dictated by ability to pay. We did do some Genials down. If we had more time, I would show you some of those restorations on the bottom. But, you know, really what we've got is, you know, somewhat of a full mouth reconstruction, largely in the, to be credited to Genial being able to assist us in being conservative with that treatment. Last thing we're going to talk about, we'll wrap it up. I've got to get to questions here real quick. I'll do this case super fast. But what we're looking at is cervical abfractions, and everybody knows what abfractions are. And, you know, a couple of things. There's a lot of studies out there that if you look at this, you know, I'm going to back you up and get you to look at this again. This is showing you every dentist on the planet has tried everything for this poor woman. Let's look at, you know, you see that we have connective tissue grafts. How are they doing? We're seeing that we've had fillings, and half of them have fallen out, okay? But, you know, basically, I want to make sure we're all on the same page here, that full mouth connective tissue grafts, that was full mouth, they all failed. With time, every cervical composite she had placed failed. And, you know, subsequently, when I show you what I'm about to do, it will fail, unless the etiology of the cervical abfractions is addressed. And I want to point that out, because I've been asked to, you know, not so much man the lines, but I'll get questions from manufacturers. Like, we've got a guy called in and said, every time he uses such and such product on a Class 5, it falls out. You know, and all I want to ask is that an abfraction. And, you know, of course, they never know that. But, of course, they want to say that the product didn't work. But the reality of it is, this is the reality of cervical abfractions. No matter what you put in there, if they're grinding or parafunction, stress. So you have, when you're grinding, you have compression on one side, tension on the other. In the area of tension, you will see enamel rods break off and this characteristic V-shaped notch. Now, dentist, if you're telling your patients that's toothbrush abrasion, I'm going to come over there and slap your hand. Because I'm going to tell you, if you gave me a drill in 15 minutes, I couldn't cut that perfect shape with a drill. I know I couldn't do it with a toothbrush. All right? This is abfraction, and it's 100% caused by flexure of that tooth through parafunction, not function, not eating and all that stuff. They're grinding, or they're clenching. They're doing something outside of the normal range. Now, here's the problem with falling out. They're going to fall out. Why? Because what you're going to attach to, you can bond with the best material on the planet. But if you don't address this, then the stuff that it's bonded to is going to fall out, and so goes your filling. So I only bring that up, hopefully you know that, because you need to tell your patient that we're going to fill these in because they're sensitive or they're carious. But, you know, until you do something, and again, I don't have time to go through all this stuff for retention rates, but understand there have been studies, flowable composites by far outweigh the best things to place in here. And why? Because you want the modulus of elasticity to actually be flexible, to be able to kind of ride out the flexure. In other words, you're going to get the best result in cervical abfractions with something with obviously a low elastic modulus. And as we said here with Genial Flow, we've got it down here lower than Filtech and a lot of these other things. Now, yes, some of the traditional flowables are actually, you know, more flexible, have a lower modulus, but they don't have the rigidity. There's this catch-22. But again, if you want to look at flexural strength, Polish is going to be another thing. A lot of these are in aesthetic areas. I got to get through this because I want questions. But you're going to abrade, you're going to bevel. I create a little trough. Sometimes a little mechanical retention in here will help. Big old bevel in there, grab the end of those prisms. And very often if they are, it's particularly if I've placed a base, which I did in these, I didn't show it, but a glass iron or RGI, I'll total etch. Yeah, I'm going to answer questions. But here's the concept. Go in, apply adhesive. I'm losing my mind, getting a little message on my screen. Fill this in, and I wanted to show you, and that's why I really think I wanted to hold out and show you this, is you pile it up in a little pile like that, and that's that cervical shade. And then what you do is you begin moving it, and you saw it's in a big pile, and you move it down to the margin, and move it over to here, move it over to here, and then once you get the base layer covered, you cure it, okay? Then what you do is you apply the next layer, and then you do the same thing, move it around, move it around. And again, here you might want to go one extra step, and I love the Diacomp kit from, or the Octrafine, and I love to kind of buff it with these little brushes. But what I wanted to show you is that the actual finish of these materials is quite comparable to the adjacent enamel. I mean, you know as well as I do that this material actually is typically down on the root. It's very hard to get a polish, and that's really probably the primary reason I want to show you that.